Welcome to Raaonline. So today we are going to see a very interesting trial, the Rescueicp trial. Okay, these trials are going to help you to decide between the two different approaches of any disease or condition which you're going to encounter in your emergency department. Okay, so in this trial, this is basically a trial of decompressive craniectomy for traumatic intracranial hypertension. This is published on 7th of September in 2016 in NEJM. Okay, and this is a reference ID which you can get it in the online. So the clinical question which has been addressed in this particular trial is, in patients with traumatic brain injury and refractory intracranial hypertension, does decompressive craniectomy result in more favorable mortality and neurological outcomes at 6 months compared with barbiturate coma and continued medical management? Okay, so this is the outline. Basically, the question is, you receive a patient with traumatic brain injury and the intracranial pressure is on the higher side. So stage 1 and stage 2, you do all the medical interventions to control the intracranial hypertension, but still it is refractory. In such kind of refractory intracranial hypertension, should you opt for a surgical management or should you opt for just barbiturate coma and continued medical management? Which is more favorable in terms of mortality and which is more favorable in terms of neurological outcome at 6 months? Okay, so this is the outline question which you are going to address. So either are you going to do a decompressive craniectomy or just a medical management, right? So this study design is, it's an international study, multi-center study, randomized control trial. Okay, so it is multicentric, so it is not dependent on one single institute or one single particular protocol. Okay, and it's a parallel group superiority study where one set of treatment is directly compared to check whether one treatment is superior over the other, and 1:1 randomization with use of permuted blocks of random sizes has been done. So what is the meaning of block randomization? The meaning of block randomization is, for example, I can choose a block randomization of 4, or I can choose a block randomization of maybe like 2 or 6 or 8 or any number like that. Okay, so the computer decides at the end of 4 recruitments, it will make sure they are equally distributed. What I'm trying to say is, for example, now I'm choosing a permuted blocks of 4. In that case, the first case by incidentally goes to the group A. Okay, the second case incidentally again goes to group A. Now the computer decides that it's a permuted blocks of 4. So for every 4 patient, it has to be equally distributed. So the computer will influence and make sure that the 3rd patient and 4th patient will go to team B, so that at the end of 4 patients, if you see, the number will be equally distributed. This can be done even at blocks of 10, blocks of 15 or blocks of 20, where at the end of 20 patients, if you see, it will be equally distributed. So why this kind of blocks is important is for 2 reasons. Number 1, for doing an interim analysis. What is the interim analysis meaning? For example, you take a study where you're going to check in among 800 patients, but you can't wait for 800 patients to get enrolled, 800 patients to have the effect, and then come to a conclusion that what you intervened is going to be dangerous, right? So you need to do an interim analysis to check whether your intervention is going to be dangerous, so that the rest of the population can be preserved, and you can even stop this particular study. Okay, this is called as interim analysis. That means checking your study, checking your trial in between, before even the study gets complete. It's called an interim analysis. Okay, so for example, now I want a population of 800 for my study. If this is going to be a 1-year study, if for the first 6 months, almost 300 patients out of 400, out of 300 patients are in group A and only 100 is in group B, I will not be able to do my interim analysis, right? And what I'm saying is, in total, I want 800 patients over a period of 1 year. Okay, so at 6 months, I'm doing my interim analysis. Now, at 6 months, say in group A, there are 300 patients and in group B, there are 100 patients. now I will not be able to do my interim analysis because grossly the number is not equal. So in such cases, if at all I apply this block randomization technique, for example, if I apply a block randomization of say 20, for every 20 patient, the computer or the randomization technique will make sure that they are equally distributed, so that at the end of 400 recruitments, if I see that A will have 200 and B will have 200, so that even by recruiting 400 people, I'll be able to do my interim analysis so that I can make sure that I'm not harming any patient, so that I can proceed for further 400 to complete my 1 year study with 800 patients. Okay, this is called as block randomization technique. Now, the modify, that excluded patients lost follow-up and withdrew consent. Okay, so this is very important. Patients who withdrew consent, who lost follow-up, are just neglected from the study, right? And now this is a intention to treat analysis. This study is done by intention to treat analysis. Hope you're aware of the term intention to treat. So what exactly is this? What is the thing of intention to treat? Okay, and this is very important. Listen, you have recruited 800 patients, for example, and you have classified them into group A and group B. For example, group A means they will get an injection A, and group B, they'll get an injection B. Okay, this is what is destined. Okay, it is not given, you are just grouped them, that's all. But over a period of time, for example, in A there are 400 patients, in B there are 400 patients, right? But over a period of time, as your study progresses, say around 100 patients in group A did not get injection A. Okay, they by some chance switched to injection B. Okay, they just got switched to injection B. Okay, and say somewhere around 100 did not get any injections at all. 100 did not get any injections at all. Maybe they got cured. Okay, so or they are allergic to the test doses, so they never got an injection at all. So ultimately, if you see, in the patients who got the injection B will be around 500, and patients who got injection A will be only 200, right? Okay, but your analysis is not done for 200 versus 500. Your analysis is not done for 200 versus 500. Your analysis is done for 400 versus 400 only. This is called as intention to treat technique. This is called as intention to treat analysis. That means how you started the study. Okay, that is the population you're going to compare irrespective of what happened to them in the due course. Okay, so 400 were enrolled in the segment A and 400 were enrolled in the segment B, where they are destined to get injection A in team A and injection B in team B. Whatsoever reason, some patients in team A got injection B, they get switched to injection B, or say some 100 patients, they never got an injection in the due course. So whatever having said and done, you are not bothered about the total end population. Okay, your analysis is based on the early population where you recruited and segregated as team A and team B. This is called intention to treat analysis. Okay.